So we did start the entire topic by saying that INR is elevated, right? Now, how do you use the INR in liver cell failure? How do you use it? What do you think we should be doing? Say you have an INR of 4. What do you, Sachin, if I tell you the patient is in cirrhosis, his INR is 4. What is going to, and he's come to you with ascites. He's come to you with gross ascites. He needs a TAP and he's come to you. What are you going to think now? INR is 4. So I'll give you the example. He is a known case of cirrhosis, alcoholic cirrhosis, with portal hypertension, which basically means that he is a decompensated liver failure. Once you develop end organs like portal hypertension, ascites, encephalopathy, you call them as decompensated liver disease, DLDs. Okay, so they are a decompensated liver failure. Now this patient is presented to the ICU with an ascites, which is tense. Okay, and he's present with some breathlessness. And then you do an INR which comes as 3.7. Okay. Now, what do you do? What is your thinking for this patient?
First of all, I need to blood test कम करना उसका.
क्या करना है?
Blood test.
You have to reduce. Very good. So you have to reduce his breathlessness. Fair enough. You want to reduce his breathlessness.
So
Okay.
For that I need to do tapping, but
You,
INR is 4.
you need to do tapping because there's ascites. Okay.
So INR is 4. I need to rule out any bleeding tendency.
So what do you do? I'm asking you what you're going to do. Your bedside, patient has come into you. My phone is not reachable. And you're alone. What do you do?
Can give sir between
Go ahead, tell me what you want to do.
between K and K.
You give vitamin K, okay? Give vitamin K. And then he's still breathless.
Tap it, sir.
Vitamin K is going to change the INR immediately.
No.
Then you're not, then why give vitamin K?
FFP, by the time I'll arrange tap it, sir.
So you will give, you tell me you're going to do FFP, give FFP, no FFP, you're going to tap.
FFP I'll give, sir.
How much FFP will you give?
I'll give 4.
You'll give 4 FFPs because?
What, sir?
Because? 4 because you like the number 4?
No, sir, because the one.
10 to 15 ml per kg FFP will be given.
So 10 to 15 ml per kilogram. So let's say 500 ml for a 50 kilo individual. So only 2 FFPs. There's only 2 FFPs. And then you tap. Who agrees to this? Who doesn't agree to this? Who agrees to this? So what Sachin says is, he'll have a patient that comes in with breathlessness, INR is 3.7, and he first thought of giving vitamin K, he gave it, you gave vitamin K, but you gave 4 pints of FFP also along with it, and then you went ahead and tapped it. Who would follow this protocol? And who would say that this is right or this is wrong? Who would say this is right? Sachin, you would say it's right, so put your hand up.
Yes.
Anybody who says this is right? Everyone else is saying it is wrong. So what you would do then if it's wrong?
So we'll also we can do few more things. Like we can do
What do you want to do?
BTCT.
So you will do BTCT here.
And
BTCT, I'm giving you BTCT. I'm giving you 4 minutes bleeding time, 11 minutes, 12 minutes clotting time. Or let it make it 18 minutes. So 18 minutes clotting time. Yes. Now tell me.
time is raised.
Now
And
I give you BTCT.
And so meanwhile we can start with the diuresis also. So since
You start diuresis. That means you will ensure that this patient goes into hepatic encephalopathy.
No dialysis.
And then you will treat hepatic encephalopathy because we now know how to treat hepatic encephalopathy. Now we know how to treat NCAP, so we'll probably first take him to NCAP, treat NCAP first.
So actually this INR patient will be more of adapted to this INR.
So I am asking you what you're going to do. Sachin says that he is going to do this. You said that you're going to do this.
No diuresis.
No need to give FFPs directly. We can.
We can tap.
So she's moved from dialysis away. Where is the taster gone? So you don't want to do this, right?
Okay. Tap directly.
Because this dialysis comes much before ascites. It doesn't come at ascites. It comes much before ascites. You want to prevent that from occurring. So you want to give a good combination of lacilactone to prevent the hypernatremia and hyperkalemia from occurring. That is why you are giving diuretics. Once it has gone to that level, then it is maintenance later on. After your first dab, then you have to maintain. For that, you give diuretics. You don't give it now because diuretics, over diuresis causes hepatic encephalopathy. It's one of the common causes of precipitation of hepatic encaph. So she differed and she said some changes. Nobody else is differing. You already pick up your hand. Huh?
I will not, I can directly go ahead with the ascitic tapping.
So you will go directly with the ascitic tapping here. Okay.
Because in these patients, INR usually remains higher side.
So you said you want to directly go for ascitic tapping,
Because
but anything
considering-
specific about this? If you think you want to do it like this, is there anything specific you want to look at or be careful about?
Blood pressure, totally pressure.
One second, let you finish. Huh?
So any active bleeding?
Anything anything specific about ascitic tap you want to do, or is this fine? Okay. Anybody else wants to change this? So she says that I will directly go for an ascitic tap. Sachin wanted to give FFP. You want to do an ascitic tap. Anybody wants to change anything here? So you all have some have not answered, not put their hands up. So what have you, Arshad? What do you want to do?
Albumin.
You want to give albumin. So Arshad wants to give albumin, but doesn't want to tap.
नहीं नहीं टैप कर दो टैप के साथ
So albumin and then tap के साथ albumin दोगे, ठीक है? But you will not change anything. You will not put FFP. You will not give.
FFP
You will give FFP also. So he just says that he will add albumin here. This is what Arshad has said. Arshad said he'll add albumin here. Okay. Who has not picked up? You have not picked up your hand. What do you want to do?
Sir, since patient is breathless, we'll go for ascitic tap, but we'll start patient on albumin and hemodynamically we will manage the blood pressure.
So you don't want to give FFP.
No, sir.
So you will tap. You will do ascitic tap and you will give albumin. Okay.
And I'll start vitamin K also.
And you start vitamin K. Anybody want to change anything here?
So the reason of breathlessness just the
Yeah. That is clear.
And it is tensed when
This tells. So
on USG ultrasonography also we just see ascites, so obviously something.
ascites. The cause is the fluid. So that is why you must understand what the entire thing about INR is about. Okay. So what do you understand by INR? What is INR? INR is equal to prothrombin time. It is normalized. That's why it's called international normalized ratio. It's normalized. That's why we believe the INR, because prothrombin time can vary from person to person depending on the reactant or that they're using over there. Okay, that's why INR comes as a normalized INR, right? So what does INR actually figure out? What does INR find? What does INR look at? What is the INR? INR is, and what is that? Prothrombin time. So it is prothrombin time. What is it? Prothrombin time. Alright. Prothrombin time is factor 2. It is factor 2. Prothrombin time is actually factor 2. Prothrombin time is factor 2. So all that the INR is telling you is how much factor 2 is there in the body. This is all that it is telling you. It is not telling you anything more than that. Okay, what does prothrombin tell you? How much factor 2 is there in the body. That's all it's telling you. That's all it's telling you. Clear? Is it clear till now? Clear till now? Well, let's go to how a body clots first. How does a body clot usually? So we all learned during our medicine days, MBBS days, as to we have got two pathways, right? They talk about the fact that there are two pathways. Okay, one was called as the extrinsic pathway and the other was called as an intrinsic pathway. They tried to make it as simple as this. They said there are two pathways, one starting from tissue factor, endothelial damage causing tissue factor, and 7 getting activated, right? So the extrinsic pathway was composed of 7 going to 5 and then leading to 10. This was what it was. And then they talked about an intrinsic pathway which actually starts with 12 and then goes down. Okay, it goes to 12 and then 9 and then goes down 10. At the end, the common pathway is 10, 5, 2 is what the common pathway is, right? This is what occurs. This is the common pathway. So this is purely enzyme, purely coagulation factors, But how actually a clot is formed? What is one of the main ingredients? Is what is the main ingredient of a clot? Fibrinogen, platelets. Where is all that gone? So actually this is only the enzymatic part. This is only the enzymatic part. Thus the enzymatic part. That is what is happening to the enzymes. 12, 11, this is all just the enzymatic part. It's coagulation factor enzymes which are working. But however, how a clot forms is first, a platelet comes, then platelet adhesion molecules come together, then von Willebrand factors get together, it forms a platelet plug. Then the coagulation factor comes in the middle, then it becomes bigger and bigger and bigger and becomes a formed clot. That's how clot is formed, right? So this means it has got an enzymatic mechanism and a cellular mechanism. Enzymatic mechanism and a cellular mechanism. So when I want to study whether the patient is going to bleed or not, I need a combination of the enzymatic as well as the cellular mechanism to be tested. Right? What am I testing here? Only the enzymatic. I am testing here only the enzymatic mechanism. You've understood this? How do they do this? They actually take the blood, they rotate it, take off the serum, throw away the cellular compartment and then do the prothrombin type. You understand? So in short, we've missed out on the cellular mechanism completely.
BTCT will be shown the cellular.
In some aspect, not completely. Some aspect, not completely. Because platelets, von Willebrand factor, fibrinogen, where is all those? It's not there, right? We want all those also. In order to understand whether the patient will clot or not, I need to know everything. This only gives you a window to just the enzymatic mechanism. Clear till now? And we say that the PT looks here, where at the extrinsic, and the APTT looks at the intrinsic pathway. The thrombin time, prothrombin time is the and APTT is the intrinsic pathways. Clear? This is what we look at. So ideally, what we want to know everything. Ideally, we want to know everything. So, if to form a clot, you will have an initiation phase. Okay, an initiation phase is usually as a result of tissue factor which comes in and then causes this pathway to start, platelets getting activated, and then platelet glycoprotein to be coming in, GP2, all these things coming inside, and then platelets get adhered to each other, a von Willebrand factor comes inside, and then there is an amplification phase. There's an amplification phase where the clot becomes bigger. So you have an initiation phase, a propagation phase, and an amplification phase. Now importantly, all of these are auto-amplified also. They've got loops inside themselves. When you see a diagram, you see all those loops coming here, there's so there. You see the diagrams, very difficult diagrams. So it's where all these things are actually going here and here, here and here, here, and auto-amplifying themselves. So there's an amplification mechanism also. So in short, the entire thing is extremely complex. This is extremely complex, and we are just seeing one part of the entire story. Okay, now let's put this all into the perspective of liver. Okay, now what is happening in liver? Let's see, the initiation phase was actually getting activated, the platelets getting activated and releasing granules, right? Platelet has to get activated. When the platelets get activated, that is when the granules get released, and that granules causes this enzymatic pathway to start. This is what is basically occurring for the enzymatic pathway to start, right? Platelets have to release those granules. That's the first initiation. So initiation is that. Now let us take what is happening in liver patients. What have you seen with platelet count in liver patients? Yeah, they have thrombocytopenia. Now why do they have thrombocytopenia? So one thing that you do as a doctor is you actually palpate the spleen. Okay, so if the spleen is big because of whatever reason, portal hypertension or whatever, the spleen has got a function of heating up the platelets. So one thing that the platelet count can be low is because of the fact that there is splenic sequestration, which is actually taking off the platelets. Then
destruction.
Sorry?
Destruction.
Why would there be destruction? So another thing that can occur is liver is the seat of a lot of proteins. Liver is the seat of a lot of proteins. So one of the proteins that liver makes is called as thrombopoietin. One of the products. So what does liver do? It creates actually thrombopoietin. What does this thrombopoietin do? This thrombopoietin is the one that stimulates the bone marrow to make platelets. It is one of the things that stimulates the bone marrow to make platelets. Clear till now? Clear? So what is happening in liver cell failure? The liver is not working, so there is no thrombopoietin, and hence bone marrow reduces the amount of platelets that it is producing. Okay. Then the third thing. The third thing that is occurring in these cases is in cases of alcoholism, the bone marrow directly is made to fail. In alcoholism, the bone marrow it works directly on the bone marrow. Even hepatitis C, it directly works on the bone marrow. The virus hepatitis C works directly on the bone marrow, again causes the platelets to go low. Okay, so this explains that the number of platelets are low. Clear? The number of platelets are low in liver cell failure because of three reasons, of which one is splenic sequestration, the second is a bone marrow depression because of hepatitis C and alcoholism, and the third is the reduction of bone marrow stimulation because of reduction of thrombopoietin, which is part of the liver. Clear? There are three reasons to cause the platelet count to be on the lower side. That is clear? Now on top of it, there is something more. What is also occurring is, what did we say as the initiation phase and initiation phase? Platelets come in, and after the platelets come in, there are platelet adhesion molecules that join one platelet to the other, and there are other big molecules which are von Willebrand factors, which actually come together to actually form a nice big platelet plug, von Willebrand factor. Okay, clear on this? What is happening is, we have a reduction in platelets. That means every patient should bleed. They don't bleed. Why they don't bleed? Because the adhesion molecules and von Willebrand factors are overexpressed. You understand? The von Willebrand factor and adhesion molecules are overexpressed because of cirrhosis. You understand? The mechanism is very clear. Platelets are low, you would expect the patient to bleed, but the patient is not bleeding because the von Willebrand factor is actually increasing. Factor 8 is getting overexpressed. Okay, factor 8 is getting higher because endothelin keeps on releasing that factor 8. Okay, because it's a severe systemic inflammatory response all the time. Endothelin keeps on releasing. That is why our sepsis patients are also hypercoagulable. You understand? They keep on releasing factor 8. Willebrand factor is on the elevated side. So, even though there are small platelets, number of platelets are low, but the adhesion is very strong. And so, it doesn't require more platelets to actually stop or form a clot. Clear? So, it's now become balanced. The low platelets have actually become balanced. Clear? The low platelets have become balanced. So, even if there is low platelet count, even if the platelet counts are like 10,000, the chances of it bleeding are less likely. However, if I want to do a procedure, I would want to keep the platelets on the higher side. You understand? I am certain that he will not spontaneously bleed. We will not get 10,000 and all. We will get somewhere around 60,000, 70,000, 50,000. This is what you normally get. You will not get 10,000 and 5,000. It doesn't cost so much. Are you understanding? So if it reaches say less than 50,000 and tomorrow I want to do an ascites tap or something that like a lumbar puncture, I'll probably give some platelets. Clear on this? Clear? So up to 50 I have nothing to worry. Ascites up to 30,000, central line 30,000 I don't worry. But I'm doing a central neurological puncture, like for example a lumbar puncture, then I'll probably give some platelets. Because background mein what I understand from the physiology is the fact that there is overexpression of the rest of the adhesion molecules and von Willebrand factor, which actually makes it very strong. Clear? Any doubts till now?
So what is the criterion target platelet for lumbar puncture?
It has to be more than 50,000. Central line 30,000. So we say central neurological puncture is always 80,000. We want to get to 80. But it has to be more than 50. Better to get it to 80. You understand? For lumbar puncture. Central line 30,000. People say even 20,000. So there are guidelines that say 20,000 for central line. You understand? But it is very difficult. Guidelines may say something. It's very difficult to at that moment say. But if you ask, somebody asks you what is the guideline, 20,000 in this liver cell failure. That's why when doctor said, these patients have pulmonary hepatic failure, Dr. Jairam said. So their platelets will be 15,000 and 20,000, but they don't go give platelets and they just do it. We just put the lines. You understand? Nothing happens. Okay.
So 20,000 you are saying in failure.
In liver cell failure. Yeah.
Even for neuraxial block also 50,000 in liver cell failure.
No, neuraxial block has to be above 80,000.
Above 80,000.
Yeah.
Normally.
Any patient in neuraxial block has to be more than 80,000. We cannot do it less than that. Okay.
So in spite of low platelets, they are more prone to form clots.
Yeah. So in spite of low platelets, these patients have got a high chance of forming DVT. Because of this reason. The reason is this. The reason is that they are very strong platelet adhesion factors and von Willebrand factors which are causing this kind of a problem. You understand? So now we have started by talking about just the initiation phase. This was only the initiation phase of the clot, right? Now the next phase is what? The amplification and propagation phase. Okay, that is where the enzymes come in. So liver actually creates is responsible for synthesizing these enzymes. Okay, so what does the enzyme it synthesizes? It synthesizes 2, 7, 9, 10. This is what it is doing. 2, even 5. 5, 2, 5, 7, 9 and 10. This is what it is synthesizing. Okay. Of these factors, one important factor that it over synthesizes, in fact this is because the liver is not working, these are not there. But if the liver is not working, it actually causes an increased amount of factor 8. The factor 8 is very high. In the enzymatic pathway, the factor 8 is extremely high. And importantly, it actually also is responsible for reducing the production of protein C and protein S. Both these factors are anticoagulants. These are coagulant factors. These are anticoagulant factors. Okay, we require both of these to actually give optimal coagulation. What it is doing, it is actually reducing this as well as reducing this. Since it's reducing both, the balance is such that there is really no bleeding tendencies. In fact, if at all there is an increase in clotting tendency because the factor 8 is high. Clear? Clear on this? So protein C, protein S is low, which are actually anticoagulants. Okay, and the coagulation factors are also low. So the overall is actually procoagulant states. The actual is procoagulant state. So actually this forms a procoagulant state. समझ में आ रहा है? So this is what happens in cirrhosis. You will find something like this in cirrhosis. Now, so if tomorrow if I ask you the same question now again, if I go back to the same patient, 45-year-old gentleman, cirrhotic who comes with ascites and having an INR of 3.7, what would you do?
Check platelet.
Maximum I'll check platelets and
protein CNS.
and entire. Maximum I'll check platelets. Maximum if I feel that this patient may be in very low platelet count, which is highly unlikely. But then when I'm doing the ascitic tapir, I'll ensure that I use the lowest blower needle. I will ensure that I'm in the right place when I'm doing it, where I'm avoiding all the vessels. Yeah, I will keep it in that place where I am certain that I will avoid vessels. I'll do it like that. So then, if this is the case, how do I evaluate these patients? If I have a patient who comes in like this, how do I evaluate these patients, cirrhotic patient who comes in to us with the INR of 3? So what is the point of doing the INR? What do you think is the point of doing the INR?
Classify.
To actually classify them, to put them into that कि भाई 7 है, or is more than 3.5, whatever. We have to decide that, right? That the patient is either in candidate for renal transplant, liver transplant. We need to classify them into that. So that is one. Second,
So how much liver is there in the production?
synthesis function. So it basically gives you how much is the liver functioning. So today, if the INR is 4, if I give FFP and it comes down, I have masked everything. I don't know what is happening to the liver. I have just cosmetically masked it. You understand? What I want to know is whether the liver is working well. And to find out that if the INR comes down on its own, I'll say, okay, the liver is working well. Are you understanding? If I take the INR of 4 and give him 2 FFPs, 2 rates come as 2.5, I've just cosmetically got that INR down. And in fact, it's become more hypercoagulable. It's not helping me in any way. But if the INR has come down on its own, what comes to my mind? That the liver is getting better. The synthesis is getting better. It is synthesizing more coagulation factors. Now it's getting better. You understanding? So the reason to do the INR, the only reason to do the INR is to figure out what is the function of the liver. That is why gastroenterologists will actually get irritated if you give plasma. If you give plasma, a hepatologist will get irritated. Why? Because he's understood that this guy knows nothing. You understand? He's just reading the numbers. He knows nothing. You got the point. No liver transplant person will come and tell you give FFP. They will never tell that. If at all FFP will cause, it will cause problems. Why will it cause problems? It will actually cause an increase in the volume. That volume will cause more splanchnic portal hypertension to increase and worsen the ascites. So it's problematic to give an additional load of plasma to a person who's already overloaded because of splanchnic vasodilatation. Clear on this? So doesn't make any sense to do something like that. Okay, giving FFP
So
to
what
this
if
particular
the
patient.
INR is more than 10 or something? Do we just know that the liver is very bad?
Yeah, we know that the liver is very bad. That person will be actually for transplant. That liver is very bad. The INR is more than
But
10.
when he comes in the same case like with ascites and breathlessness, so do we tap such patients?
So in these cases, you need a higher investigation. So that is why we need these patients in a liver. So which is the higher investigation we need to do in these cases? That's the question. That's why you try to do a higher investigations here. When a patient comes like this to you with the INR that is elevated, I need to understand the system a little bit more better. That is very clear. I need to understand the system more better. I need to understand the platelet function. I need to understand the enzymatic pathway. I need to understand it, the fibrinolytic pathway also. I need to understand everything together, isn't it? And to understand this together, one of the investigations that you can do is whole blood coagulation assays. When I say whole blood coagulation assays, there are a number of whole blood coagulation assays which are called as ROTEM, which are called as thromboelastography. Okay, TEG. Is it TEG? No, TEG. That TEG is thromboelastography. Okay, there is something called ROTEM. There is something called as FIBTEM. Okay, these are all whole blood coagulation assays, whole blood clotting assays. You understand? Whole blood clotting assays. But it is taking the whole system, it is not removing the cells out. It is taking the cells also and giving you everything. समझ में आ रहा है? वो cells को भी डाल के बता रहा है कि भाई कुछ idea दे रहा है कि भाई the cells are not working or this is not working. None of these tests are completely certain. Okay, but it will give you more idea than just your INR. Okay, give more idea than INR. So what is this thromboelastography TEG? What does TEG do? TEG में क्या करते हैं? They take this blood out and they simulate clotting outside. They simulate clotting outside and it gives you a figure that looks something like this. It gives you a figure something that looks like this. Now what are these parts? You must know these parts.
Initiation time.
Yeah, so this, as I told you, initiation, propagation, amplification. That is how we think. So to initiate the entire thing, you need the tissue factor pathway to start, which is the enzymatic or cellular? Enzymatic part. It is the enzymatic part that kicks in first. You need the enzymatic pathway to start first so that tissue factor is released and this is working. So that enzymatic part is this part. This is called as R time. So when you see a TEG report, you will get an R time. Okay, this is the R time. So the quicker it is, that means the faster he is coagulating. The faster is his initiation to clot. That means faster is his enzymatic pathway, better is his enzymatic pathway. The faster it is. Right? Clear on this? So अगर ये मेरे को 3 सेकंड मिला, we are very fast. It's quite fast. It's extremely fast. It's got its normal values. You can anytime see 3 to 10 normal होता है. 14, 15 हो गया तो बहुत ज़्यादा हो गया. So if it is very high, means the problem is where? There is a problem in the enzymatic pathway. It's very clear in this. Okay, the problem is the enzymatic pathway. So what I would like to give is this is prolonged. What I would like to give? Factors. Coagulation. FFP. I give plasma, fresh frozen plasma. What factor give I don't know. But plasma is enough. I give plasma here. समझ में आ रहा है? I'll give plasma here. Clear? Clear till now? Then this is the next part of the story. We want the platelets to join together and become a strong clot. So this part is called as the maximum amplitude. This is called the maximum amplitude. Okay, the maximum amplitude actually signifies your strength of your clot. And the strength of your clot is a factor of platelet function and fibrinogen function. That's what it is basically. It's the strength of your clot, how strong the clot is binding. So it's like a platelet function. So not actually platelet function, but it gives you an idea that the clot that is forming is not very strong. So I may want to give things that will strengthen the clot, which includes platelets, which includes fibrinogen. Clear? I may want to give something, if my MA time is not okay, I will want to give something which will give my clot to become more stronger. Right? And this end में जो time दिखता है, this is called as LY30.
Lysis.
That is fibrinolysis at 30 minutes. Fibrinolysis. How quickly it is lysing. So ऐसा भी हो सकता है कि patient is lysing regularly and very fast. So at this stage, if he is lysing very fast, I need to give something that is anti-lysin. That is anti-plasmin. Huh? Plasmin, like plasmin. I want to give plasmin. Or I want to give tranexamic acid. You understand? So by looking at the tech report, of course there are some alpha angle and C level and all those things. We don't need to look at all those things. Just we look at these things. We look at R value, R time, that is. We look at MA amplitude, maximum amplitude, that is clot strength, signifies clot strength. Then we see LY30, which is basically a fibrinolysis time, which will give an idea whether it will give anti-lysin, anti-fibrinolytic drug. That side, in the center it will be platelet and fibrinogen, and this side will be plasma. So tomorrow if you have a patient with an INR of 10, I will do this. And see what is happening. If my INR is 10 and my R time is also prolonged, means I have to give him plasma. I will have to give him plasma to do the procedure.
But sir, check will take time, like INR is
Eight.
These patients are going to die immediately. The benefits of waiting are much better than the risks that you're taking.
Will do that.
What? Benefits of waiting? I'll wait, no, INR 10 रहेगा. He's going to die immediately. मरने तो नहीं वाला है, he's just breathless. Wait for him. Take a report आने दो. Take a report को 30 minutes लगेगा. Let that report come out. We used to have take over here in a hospital for a long time. We just stopped doing those things. Okay, so we get the answer here.
Sir, MA time, if it is maximum, that is the strength of the platelet.
Strength of the clot
If it is MA time is low, then the clot is poor, the platelet function is poor.
is poor. So उसमें लिखा हुआ रहता है. मतलब ये जो भी when you see this, no, उसके बाजू में ऐसा लिखा हुआ रहेगा. MA normal value 30 to 70, 50 to 70, sorry, ऐसे लिखा हुआ रहेगा. Less than 30, this is the problem. ऐसे लिखा रहेगा उसपे. You give fibrinogen, give platelet. ऐसे लिखा भी रहेगा उसपे. So you don't have to worry. You don't have to think too much. You understand? It is there. It's written on the report itself. Any report, if you open the so now let's go back to a patient that we recently had. That patient, cirrhotic patient. That cirrhotic patient had an INR of 1.8, 1.8, 1.9 कुछ तो था. Can you open the tech report of this patient? Where is that patient's tech report? Group है. Huh? So now that you know this, now that patient has to go for surgery. It's not so simple. You have to go for surgery. Huh? So let's go and see what the tech report was all about. Can you open the tech report of this patient? Anybody? Anybody who has a tech report of this patient? You got it? So let's read it out. So you would have expected this patient to be coagulopathic, right? Let's see the R time. What is the R time? What is the R time?
Our time is 2.2 minutes.
2.2 minutes.
And what is normal?
Normal is
2 to 8.
So 2.2 is normal.
low normal.
But it's normal.
It is normal.
Then MA
MA is 52.2
52.2.
Semi normal is 60.
In spite of the fact,
Low
in spite of the fact that the platelet count is 82,000. उसका platelet count is 82,000. Okay, 52.2.
And normal is 51 to 69.
Yes, it's normal.
Yes.
L by 30
And was 0%.
means normal.
0 to 8 is right.
Normal. So what is this patient's situation? It's completely normal.
Population factor deficiency, fibrinogen level normal, platelet function normal, no lysis.
Exactly. So that patient was normal. You understand? Huh? That is why when somebody asks me इसको plasma देने के बाद ऐसे नहीं देने का मेरे को plasma. Plasma is given for different reason in that case. Hypovolemic, has constipation, passing Dufalac. You know, एनीमा देख के हम लोग उसको निकाल रहे हैं. This way I was giving it as part of the volume. You understand? It is not related to FFPs. You understood now? So now you understand that this patient was completely normal. In fact, if at all, he is hypercoagulable. If at all, 2.2 is not low normal. It is in fact hypercoagulable. This side, lesser the R time means faster. So he is actually towards hypercoagulability. You are understanding? समझ में आ रहा है?
Factor 8 is
Probably causing that. Whatever the factor that one we don't know, but he is towards a hypercoagulable side. You understand? He's more towards the hypercoagulable side. You understood the take report? And you understood why I did the take report also now? Because I want to exactly know, because he's going for surgery. कल जाके surgery के लिए जा रहा है, ऐसा नहीं लगना चाहिए कि भाई I'm missing out on something, something is wrong somewhere, I need to change something. You got the point? Any queries?
So can you repeat those low platelet count thresholds for cirrhotic and non-cirrhotic patients?
Low platelet
Threshold for procedures.
procedure. So if you have a neuroaxial procedure like a lumbar puncture or a cerebral surgery that needs to be done, for example, it's an IC bleed, okay, and you need to do some kind of operation into the brain of the spinal cord, like an LP also, if you want to epidural catheter you want to place, something like that you want to do, it has to be more than 80,000. It has to be more than 80,000.
For all patients,
Yeah.
cirrhotic, non-cirrhotic.
Cirrhotic more, no, so non-cirrhotic 1 lakh. 1 lakh. So this is 80,000. Whereas central line and other procedures which are non-bleeding risk, non-high bleeding risks, they can be done, I mean, colloquially 30,000, but there are even statements of 20,000. So up to 30,000, you require them to be having at least platelets 30,000
For cirrhotic.
for cirrhotic patients. It is obvious, no? This patient's platelet count is 82,000. Look how perfect he is. He's hypercoagulable. You understanding? He's hypercoagulable, doesn't need anything. Understood, na?
For non-cirrhotic, we can take 20,000 approximate more than this.
Non-cirrhotic, no, 50,000.
Right, but 20,000 more than cirrhotic. Like for central line 50,000.
Central line 50,000.
50,000.
Yes.
For cirrhotic we asked for 30,000.
Yes.
20,000 more than
Yes, yes,
cirrhotic.
approximately.
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 Yeah.
lumbar puncture is cirrhotic.
We are putting also. Very time you put it, later on पता चलता ऐसा है. देखा है ना बहुत बार किया तुमने. Very time you put it also कुछ होता नहीं है. नहीं होने वाला है क्योंकि वो liver है. हमको पता है liver कैसा काम कर रहा है. हम लोग को know what we know ना what liver is doing. You understand? So how do you tackle this then? So if you have a patient that comes into you, how do you tackle this? If say for example you have an enzymatic pathway that is down, okay, so what can you do in these cases to prevent? So what happens if a patient comes to you? You've seen this very often that you put in a central line and थोड़ा सा bleeding चालू ही है वहाँ पर, हाँ, या थोड़ा इमेचुरिया चल रहा है, उसको एंडोस्कोपी किया, पोर्टल गैस्ट्रोपैथी आया, तो थोड़ा सा ब्लीडिंग चालू ही है, बीपी है ना, पेशेंट आया लिवर सेल फेलियर का, उसका एंडोस्कोपी किया, दे राइट ओवर देयर पोर्टल गैस्ट्रोपैथी, हाँ, एंड देन हेमोग्लोबिन फिर भी एवरी डे 0.5 ग्राम से ड्रॉप हो रहा है, 0.5 ग्राम से ड्रॉप हो रहा है, हाँ, व्हाट इज दिस? ये क्या है? What is this? You understand what I'm asking you? You have this patient, okay, this patient's INR was deranged was 4 or something, and you do a TEG report and the TEG actually, I mean you do a INR normal which is 4, you don't do a TEG in all patients, you know, you put in the central line and now next day you find that you know slightly वो कम हो गया है, मतलब थोड़ा सा bleeding हो रहा है, hemoglobin थोड़ा drop हो रहा है, उनका एंडोस्कोपी किया, गैस्ट्रोपैथी आ गया, it was not varices, it was gastropathy and that's bleeding. Because why is it bleeding? Because next day hemoglobin is 1 gram drop. How do you approach this patient and what is this? So you'll have to think whether this is disseminated intravascular coagulation. You start thinking like that. Okay, because what I have understood in this entire today's topic is the fact that these are hypercoagulable patients. I have understood this much. But if now I am having an entity where I have put this, but the patient is having some small bleeding, yeah, something is happening. Some ooze is happening, इधर से थोड़ा सा bleed आ रहा है, टाइनाफ्रास लगा के रखा हुआ है, थोड़ा सा हेमेचुरिया हो रहा है, उसका जो GI का bleed कम नहीं हो रहा है, something is happening, right? Ideally, he's not supposed to bleed, right? He's not supposed to bleed. If he's bleeding, means there are two entities that you should think of. One entity is DIC, and the other is intravascular coagulation with increased fibrinolysis. Intravascular coagulation, acute intravascular coagulation. This is different. Disseminated intravascular coagulation is different from acute intravascular coagulation with fibrinolysis. What is the difference between both? What is the difference between both? If I ask, anybody can answer this?
There is a consumptive in there.
It is a consumption. It is a consumption here. Okay, here there is consumption here, and here lysis is happening. There are two different entities. Okay, this is consumption, whereas this is lysis. So what would be the difference in, say, for example, platelet counts?
It is low. It will be low.
Here the thrombocytopenia would be very major, whereas here the thrombocytopenia will not be as major as that. Then INR, PTT, all that should be there, but here also should be deranged. Because this is liver cell, no? Cirrhosis to hai. Then What is
Sick
specific?
patient will be very sick. I think it's like-
This consumption here, so platelets are consumed. What else is consumed here?
Protein factor.
Factors are consumed. So which factors consumed? All the factors are consumed. That's why the INR is deranged, right? But here, which factor does not get consumed or which increases? 8. So here we do a factor 8. The factor 8 will be, whereas here all the factors will be low. Are you understanding? That's what DIC
We
is.
should be
There is
responsible
some
to
acute
antifibrotic.
Acute intravascular coagulopathy with acute fibrinolysis. Now you go back to egg.
This will be responsive to antifibrinolytic.
We'll come to that now. So let us come to the fourth topic, then you'll understand. Fourth, what is happening here? In DIC, this is prolonged. This is my maximum amplitude is changed, is showing low clot strength. LY30 is increased. Here what is happening? Only the LY30 is showing fibrinolysis. LY30 is affected. LY30 is affected. You understand? So there's a difference, right? So when this is occurring, only the LY30 is changing. The rest everything is okay. When this is occurring, everything is also changing. Clot strength is also going down, consumption हो रहा है ना सब जगह. So that's why it's actually changing everything. Whereas here, generally only the LY30 is going to change. Right? Clear? So then what would be the treatment of this?
This PM platelet will be so
For
it's like
DIC.
DIC.
So for this, what I would like to do,
Tranexam.
yeah, the answer would be tranexamic acid here. The answer here would be stopping this by giving tranexamic acid. That's why very often you see, no, patient has come in with that need, you give tranexamic acid, next day वो ठीक हो जाता है patient. देखा है ना? Next day वो ठीक होता है. वो क्यों होता है? क्योंकि it is this entity. It is this acute intravascular coagulation with acute fibrinolysis. This is the entity that they have.
So that Harish Satranji patient can get blood when given Tranexam bolus.
Which one patient?
That Harish Satranji sir.
Fungal sepsis.
Clostridium difficile. Who are severe.
No, that was bleeding. That was hemorrhaging. That was hemorrhage. That is going. वो तो completely अलग level है. That is different. What we are talking of is a patient who came in. His INR was elevated. He had some hematomesis. You took him for a endoscopy, portal gastropathy. This is the usual story. Portal gastropathy. And then next day you come, you have put the line से थोड़ा सा ऊज़ हो रहा है. वो होता है. This is very common. Okay, and that entity is actually this thing. You understand? So for diagnosing this classical patient will not be the one that's bleeding like a tap. This will be like a nose. This guy will be like a nose. You understand? Whereas this guy will be a very sick person. Very sick person. This person, this girl or guy will be a very sick person. This will be a person who is recovering, but his slight nose is happening. You understand? That's the difference between clinical features between both. And this is the pharmacological. This is the how you differentiate between both of them. There is a possibility to differentiate by doing factor 8. That's the easiest thing to do. If you do a factor 8, you'll find the factor 8 to be high on that side. That is here because it's consumed, it will be low normal. Low normal or low. You understand? Clear? The treatment of this will be tranexamic acid. Now, the treatment of any of this, when you look at liver cell insufficiency, treatment of any of this, if the patient goes into a situation where there is a problem of any of these, you can either do a TEG, but if you don't have a TEG, what do you do? If you don't have a TEG, the only thing you can do is give an antifibrinolytic agent, give fibrinogen, give platelets. This is the only thing you can do. You understand? Just increase all of them together. If you don't have the TEG in your hand and the patient is bleeding tremendously, you have nothing else. The only way you can do is bump up the platelet function. You can give desmopressin to bump up the platelet function. It will increase the platelet function. Usually when there is uremia along with hepatic problems, you can bump up the platelet function. You may want to bump up the platelet levels up, and the second thing you can do is give fibrinogen if it is less than 200. If it is less than 200, you understand? So don't give fibrinogen blindly. That means don't give cryoprecipitate blindly. Fibrinogen or cryoprecipitate give only if the level is less than 200. In DIC we see less than 100. Clear? If it less than, I want to keep my fibrinogen in the level of 150 to 200. Because at the end of the day, fibrinogen is going to cause the clot strength to get better. Clear? Clear on this? So this is about the coagulopathy management of cirrhosis. Okay?
Also,
नीचे से करो understanding. So the